So I think this is the first neurocritical care cases and pearls that we've had in a little while, but hopefully for the next couple of months, we should have them at the beginning of the month, every month. And the purpose of this series is to kind of go through some cases and to talk about some major issues in a big neurocritical care topic. So today I'm going to be talking about status epilepticus. I have no financial disclosures to report, but I will be discussing some material from the Cerebell Inc. company. And our objective here is just kind of go through some of the basics of the initial management of status epilepticus, which is a potentially life-threatening complication of neurosurgery and of neurosurgical disorders. So our first case is a 48-year-old undomiciled man with an unknown past medical history who presents the emergency department in a prolonged generalized tonic-clonic seizure. According to EMS, the patient's seizure onset was witnessed and began 14 minutes ago. Thus far, he's received Ativan 4 milligrams IV, and on exam, he's having rhythmic movements of his right arm. Okay, so what is his next best step? So, Alex Schieper, what would you, which one of these would you like to do? Is Alex there?
Sorry, it was mute. Sorry, do you mind just going back a slide?
Sure. So we have a 48-year-old man who's having a very long generalized tonic-clonic seizure, been seizing so far for 14 minutes, and he's already received Ativan 4 milligrams.
Got it. Thank you. And then can I see the answers for it? Okay. So I would then give another dose of 4 of Ativan and load with phosphate.
I agree. So under the new definition of status epilepticus, which was made by the International League Against Epilepsy in 2015, they defined 2 separate time points. The first one is the T1 time point, which is a way of defining what is an abnormal prolonged seizure that deserves and merits treatment. And then in the second time point, the T2 time point, at what time the seizure is expected to have long-term consequences, such as neuronal death and injury. The prior seizure definition that we had used is a seizure lasting for more than 30 minutes, but this is no longer used. But I did see it in a couple of neurosurgical report review books, just something to keep in mind. So for a patient, for example, who is in generalized convulsive status, the T1 time point is 5 minutes, so the time at which you should initiate a treatment, and the T2 time point is 30 minutes. For different seizure types, the T1 and T2 time points are different. So I'm sure all of you have seen a patient who's not necessarily in having a generalized tonic-clonic seizure, but is in fact having focal seizures with impaired awareness. This used to be called a complex partial seizure, but the definition changed a couple of years ago. And in that situation, the seizures still merit treatment, but the time points are a little bit different. So the T1 time points, the time point at which you should initiate a therapy for focal status epilepticus with impaired awareness, is 10 minutes. And we actually don't know exactly how long it takes for the brain to suffer long-term consequences as a result of that prolonged seizure. We suspect it's longer than 60 minutes. Absence status epilepticus is the disease process that we typically see in children, and it's a generalized seizure type. And the T1 time point has been defined as 10 to 15 minutes, but we actually don't know how long the patients will have to seize before they suffer long-term consequences. The initial and mainstay of initial status epilepticus management are IV benzodiazepines or IM benzodiazepines. Here in our hospital, the status epilepticus protocol calls for the administration of lorazepam up to 0.1 milligrams per hour. If I were to define a mistake that young physicians make when they're first starting to manage status epilepticus is they tend not to give enough Ativan in order to try to control the seizures before moving on to something else. And then with particularly with your second dose of Ativan, it is indicated to load with another second-line AED. There was a trial last year called ESET, which defined the doses and that these 3 doses of these 3 medications were roughly equivalent in terms of their efficacy in this setting. And that's fosphenytoin at 20 milligrams per kilogram, valproate at 40 milligrams per kilogram, and levetiracetam at 60 milligrams per kilogram, which is Keppra, and there's quite a lot of Keppra, actually, up to 4.5 grams. I like to think of this as the 20, 40, 60 rule, but it's important, if you're going to remember that rule, to remember which medication is which. Okay, so Alex's patient received 4 milligrams of Ativan and fosphenytoin 20 milligrams per kilogram, just as he said. And the abnormal movements have stopped, so he's successfully controlled the convulsion. On exam, however, the patient is stuporous with sonorous respirations. He's opening his eyes to deep tactile stimuli only and making incomprehensible sounds. His vital signs are as above, and I think notably his O2 saturation is 82% on 6 liters via nasal cannula. So what should you do next? So Abhi, what do you think we should do?
Given the vitals and the exam, next step would be to intubate the patient as soon as possible.
I agree completely. So the important part, like status epilepticus is a life-threatening emergency, and the most important part of the initial management of any life-threatening emergency is focusing on the ABCs. So that's airway, breathing, circulation. And particularly in status epilepticus, where you're expecting to give a high dose of a benzodiazepine, many patients will hypoventilate and fail to protect their airway, particularly after they get the full dose of 0.1 milligrams per kilogram of lorazepam. So I agree. I think the most important thing to do next is intubating the patient before proceeding with some other treatment. In ENLS, they specify a couple of other things on a checklist. That includes checking a finger stick glucose, because hypoglycemia is actually quite a common, very reversible cause of status epilepticus. Making sure that we obtain some IV access. Now that your patient stops shaking, it'll be a little bit easier. Getting a full set of vitals, sitting a full set of labs. A head CT will be appropriate for most cases, unless you know what the cause is really clearly. And ultimately, continuous EEG monitoring is very important, because after generalized convulsion, ongoing non-convulsive seizures are quite common. Okay, so the patient's close friend arrives with the patient's home medications and is able to provide a history. And based on the history, you're able to determine what his most likely cause of status epilepticus is. What is the most common cause of status epilepticus? So let's see who's here. Trevor Hardigan, what do you think? Maybe Trevor's not there.
I'm here. My thought would be that the patient has a known seizure disorder and just became subtherapeutic on their AEDs.
I agree. In fact, that is the most common cause of status epilepticus throughout our country and throughout the world. A couple of these other ones are quite likely as well, particularly alcohol withdrawal and hypoglycemia. That's totally right. So the leading causes of status epilepticus are a known seizure disorder with subtherapeutic AED levels. The number 2 actually is alcohol withdrawal, which presents as generalized convulsive status. Number 3 is a drug toxicity, and number 4 is a CNS infection. The less commonly seen are new structural lesions, acute stroke, anoxic injuries, and metabolic abnormalities, particularly hypoglycemia and hyponatremia. But I feel like in our practice, we tend to see more of those, including new structural lesions. Okay, so the patient gets intubated. He receives some additional Keppra and is started on a low-dose propofol drip. He gets connected to EEG, which shows this following pattern. Now, this is a little tricky. So I'm going to say that I'm going to let you guys know that these are GPDs, generalized periodic discharges, and they go up to 4 hertz and fluctuate. So let's see, Ernest, what do you think we should do next?
GPDs. So I think this is an interictal pattern, so I wouldn't treat this.
Okay, I think that's quite close. So the ACNS defines non-convulsive status as, in this context, as a GPD is more than 3 hertz. So I think in this situation, and it's a little tricky, I would go ahead and start him on a Versed drip for this pattern, which is the 0.2 mg per kg IV followed by a 0.2 mg per kg per hour drip. And what I would highlight about that is that this dose of Versed is actually quite a lot. It's much, much more than you would use typically for sedation in the medical ICU. Another mistake I feel like early status epilepticus managers make is that they don't give enough midazolam. So we frequently get calls on the NEMAT hotline for patients who are, continue to be in status despite 4 milligrams an hour of Versed. The starting dose here is for like 100 kilo individual would be about 20 milligrams per hour. Okay. So this patient is in generalized periodic sharp waves up to 4 hertz, which are consistent with non-convulsive status. And in fact, he's in refractory status, which is defined as a patient who persists in status despite an adequate dose of a benzodiazepine plus a second-line anti-epileptic drug at an appropriate dose. So the treatments that we use for refractory status epilepticus here, I would say our first-line agent at Mount Sinai is typically midazolam, which is started at 0.2 mg per kg and goes up to 2.9 mg per kg per hour, which for a 100 kilo individual would be 290 milligrams an hour, so quite a lot. At those doses, you'd expect to see worsening hypotension and acidosis. Our second-line agent that we typically use here is ketamine. We started at typically about 1.2 mg per kg per hour with a bolus, and our max dose here is 7.5 mg per kg per hour. Ketamine acts in a different way than midazolam. It's an NMDA antagonist, so it can be helpful for patients who are no longer responding well to benzodiazepines. It also has as a side effect hypertension, which means it can act very well as a second agent when paired with Versed, which causes hypotension. The other 2 agents you'll see a little bit less frequently, and that's propofol, which is probably the most common treatment for status epilepticus that's used in the community. My issues with propofol is an excellent agent. It's a GABAergic agent, and it acts in a similar way to midazolam, but at comparable anti-status doses, it causes a lot more hypotension and some other end organ injury in my experience. So we tend to use a little bit less. We're also not able to use it for as long because it can cause a propofol infusion syndrome. And probably our last line agent that we use here at Mount Sinai is pentobarbital, which used to be the agent of choice for refractory status probably 20 or 30 years ago. It's an incredibly effective agent. It will control status in my experience that can't be controlled on these other drugs, but it has an enormous number of complications associated with it, including cardiac suppression, hypotension, immunosuppression, and hypothermia. So I would say we would only use this if everything else was ineffective. So our second case is a 72-year-old woman who is now post-op day 4 following resection of a left temporal mass. Frozen pathology is consistent with a high-grade glioma. Her surgery was initially uncomplicated, but since then she's been periodically confused, often speaking and interacting with her deceased husband as if he's still there. The CT scan shows expected post-surgical changes only. What should you do next? Let's see who's here. So Travis, are you here?
Yeah, I'm here.
Okay, what do you think we should do next?
Can you go back to the previous slide, please?
So we have a woman who's having probably some visual hallucinations after a surgery of a resection of a left temporal mass.
Okay, you can go forward.
Okay. So we can give her some empiric Ativan, connect her to EEG. We can treat her for postoperative delirium. We can get an MRI of the brain, see if we can get some more detail that way. Or we can start her on ceftriaxone for treatment of a urinary tract infection.
So if she's already had head imaging, I wouldn't get another MRI. I'd put her on EEG.
I agree. In this context, visual hallucinations can represent focal seizures. And so I think it's important to rule that out before proceeding further. Now, it is possible that these visual hallucinations are just part of a delirium syndrome, but I think once you really need the EEG in this context in order to rule out seizures that could potentially be treatable before describing this as delirium. So if the EEG, I would only say that the EEG was negative, that further workup would be indicated in order to determine what the underlying cause of the delirium was. Okay, so our third case is a 69-year-old woman with a history of coronary artery disease who fell in her bathroom and comes into Mount Sinai, Brooklyn with lethargy and confusion and is found to have a large left-sided acute subdural hematoma with 10 millimeters of midline shift. She's brought to MSH and then underwent the emergent craniotomy with evacuation. Post-op, she's awake, alert, oriented, and has just a right cranial drift and some mild word-finding difficulties. On post-op day 2, however, she begins having episodes where she stops speaking and starts smacking her lips. Over the course of that day, the episodes increase in frequency and are now occurring once every 2 minutes without return to baseline in between. So you connect her to EEG and it shows this pattern. And just to kind of highlight some of the features that I'm seeing here, I'm starting to see some increasing rhythmic activity that's right over the left frontocentral area. And over time, it seems to increase in rhythmicity. It's associated with some spike waves as well. And then as time goes on, it spreads through the rest of the left hemisphere and also seems to appear to involve the right hemisphere, which is a little bit harder to see because it's obscured by artifact. And then it increases in amplitude and decreases in frequency over time and then breaks up and is followed by a period of slowing. Okay, so if you assume that by the time of connection, this patient has been having this for 2 hours, what would this pattern be called? So is it complex partial status epilepticus, focal status epilepticus with impaired awareness, epilepsia partialis continua, or absence status epilepticus? So let's see. Ray, are you there?
Yes.
Okay. So which of these do you think this is?
Complex partial status epilepticus.
So I would say, generally speaking, I would agree because I don't like it when they change the names of things. But a couple of years ago, the ACNS redefined the definition of, or reclassified how complex partial status epilepticus is called. And that's now the official name that you're supposed to use is focal status epilepticus with impaired awareness. So that's what you'll see in the literature now. But you're right that this is what we've classically always called complex partial status epilepticus. Okay. So according to the new definition by the International League Against Epilepsy, at what point should we initiate, into the course of the status, should we initiate the treatment for the patient? Let's see. Is Matt Carr there? Maybe not.
Yeah, I'm here.
Okay, so what do you think? 5, 10, 15, or 60 minutes?
I think this would still be 10 minutes.
That's exactly right. So the T1 time point for focal status with impaired awareness is 10 minutes. Okay. So in our fourth case, we have a 72-year-old man with a large left anterior fossa meningioma who's scheduled for surgery later this week. 3 days prior to the surgery date, he presents the ED after having an episode of right-sided shaking at home. In the ED, the episode recurs and is followed by a generalized tonic-clonic convulsion. Seizure stopped on its own. He isn't given any medication. His head CT shows a stable appearing tumor with associated vasogenic edema that seems stable from his prior imaging. 20 minutes later, you are consulted as the junior neurosurgery resident. On exam, you notice the patient is withdrawing minimally to pain. So you become concerned that he may be having ongoing non-convulsive seizures and ask that EEG be connected. Unfortunately, it's 3 a.m. and the EEG tech is not available. So what should be done? I have to say that I find this to be one of the most challenging things, one of the most challenging parts of an ED evaluation of a patient with a seizure, which is a patient who's had a seizure for some period of time. The seizure has stopped, but the patient hasn't returned yet to baseline. And I think it's tricky to try to determine, is this patient just in a postictal state, or is the patient having ongoing seizures? Ongoing, in this case, non-convulsive seizures. So is Halima there? Maybe not, because she's in the NSICU.
She's on vacation this week.
Oh, sorry. Let me see who's here. So, Abhi, what do you think should be done instead? So we could treat empirically with Ativan 4 milligrams. We could just put the patient in the NSICU and observe them. We can just start a maintenance dose of Keppra, or we could connect the patient to Cerebell rapid response EEG.
To be honest, I don't really see a downside of, I would just give the patient Ativan 4 milligrams, see if the patient breaks. You know, and if needed, the patient deteriorates further, we can always obviously intubate and then send the patient to the ICU. But I think that would be the first step.
I think that's I think that's a really good thought, because I think, you know, the concern that the patient may be having ongoing non-convulsive seizures is really significant, and you should be able to make that determination clinically giving Ativan. However, giving a patient who's already a little bit stuporous Ativan 4 milligrams is likely to cause problems. He may hypoventilate as a result. He may lose his airway as a result. And he may need to be intubated. So it's not an intervention without risk. So in this situation, and this is a little tricky, I would connect the patient to Cerebell rapid response EEG. So Cerebell is a relatively new system that we have at Mount Sinai. It's come online since March. It's a new company, and what they do is they create these headbands that can be applied pretty easily at the bedside. So far, all of our attendings, fellows, APPs, and nurses in the NSICU have been trained to put them on. You basically just attach this headband around, and then you screw in each of the leads with that has a little bit of gel on the end, and then connect it to this receiver, which has a direct uplink to Wi-Fi and transmits the EEG data directly into the cloud. So it only takes about 5 to 6 minutes to set up Cerebell. An EEG tech is not required. And you can use it to make an immediate triage decision about whether or not the patient is in non-convulsive status and would merit administration of a benzodiazepine. There are a couple of different ways in order to determine whether or not the patient is seizing by using Cerebell. For the first is that there's a screen on the device itself, so you can look to see if the patient's having rhythmic activity. If you're not necessarily used to seeing rhythmic activity on EEG, you can hit this blue button on the side, which has this audio function where if it detects rhythmic activity, it makes this kind of bizarre laughing sound. And then the third way is that because the EEG data is transmitted directly in the cloud, you can call me and I can interpret the EEG data for you at any hour. And then we should be able to make a decision about whether or not benzodiazepines are indicated based on that. So this patient gets connected to Cerebell, and it shows this pattern here. So there's some increasing rhythmic activity that begins in the area just over where the brain tumor is, and then kind of evolves over time. We're only seeing the first couple of seconds of what's likely a seizure here. So this is recognized, and the patient gets 4 milligrams of Ativan, after which the seizure activity stops. Curiously, in this case, the patient's mental status improved significantly, and we were able to just start a maintenance dose of Keppra without having to load another AED, and then his exam improved slowly over time, and he didn't experience any further seizures. Okay, so this is just a little bit of a pitch for this new system that we just acquired. It's a quick and reliable way to get EEG data. It can help make rule in non-convulsive status epilepticus. Because it only gives you the temporal chains, it doesn't necessarily rule out the possibility that the patient's still having very small seizures and their parasagittal chains. It's now available in the NSICU, just unfortunately at Mount Sinai Main Campus Hospital. If you have a patient that you think you're trying to make a decision about whether or not they're still in non-convulsive status, you can ask that this be applied. In fact, you can even learn how to apply it. It really only takes a few minutes to learn. And the EEG data is available within 5 minutes online or on the device, or you can use this brain stethoscope, which has a very characteristic sound. I would say that the sound it makes during seizures is kind of I don't know, haunted. So I would press that, keep that in mind if you press the button. Okay. So I think overall, the kind of takeaway points are that status epilepticus is a life-threatening condition that should be treated promptly in order to prevent neural injury. The mainstay of initial treatment is benzodiazepines. When giving a benzodiazepine, you should load a second-line agent. You can use the 20-40-60 rule. And then if these measures fail to control seizures, I would rapidly move to intubate and initiate an anesthetic drip for the treatment of refractory status epilepticus. And if you're not sure if the patient is in ongoing status, you can use Cerebell or other EEG technology in order to do that. Do you guys have any questions?
That was really awesome. Thank you.
Thank you.
When you apply if somebody applies Cerebell, are you able to see the recording from offsite by signing on the website?
Yes, I am. In fact, so I have been able to review EEG data from Cerebell within 5 minutes, both at home, when I was babysitting my nieces on my iPhone. It goes directly into the cloud and can be viewed anywhere on the web.
Do they have somebody who reviews it if you want that to happen? Or is there an automatic algorithm? And if so, how accurate is it?
So they have an automatic algorithm called Clarity, which will indicate your overall seizure burden, and which is also apparent on the device itself. So it has a predictive algorithm that will indicate how likely it is the patient's having a seizure at any given point. They have some data to support it. They're still testing it to a degree. I would say that it is pretty good, but probably not as accurate as a human reviewer.
Okay. Has this been published on?
Yes. So they have evidence demonstrating that it is almost equally effective to EEG in terms of ruling in non-convulsive status epilepticus, and that the EEG data that it gets for the 2 chains that it records on, the temporal chains, are accurate.
Do you use it for continuous monitoring?
I think there are some limitations in terms of continuous monitoring. The first is that it's only FDA approved to be used for up to 10 hours, after which the contacts with the headband tend to degrade a little bit, and there are some concerns about skin issues at that point. The issue that I've had is that there is no associated video, so sometimes it can be really challenging to detect the difference between certain artifacts and actual seizures. So for example, like rhythmic artifacts, like we have when patients get chest PT in the ICU, they tend to get shook in a rhythmic fashion. That can kind of look like a seizure on EEG, and it's nice to be able to have that video to try to detect what's an artifact and what's a seizure. So Cerebell doesn't have video, so sometimes that can be tricky, and if the patients are doing other things, it's hard to tell exactly what's going on during the event. But it can be used for up to 10 hours. In fact, during COVID, because we wanted to try to decrease our utilization of conventional EEG, and because of the risk of potential infection to the EEG tech, we used a lot more Cerebell and used it for periods of, I think we had one on a patient for almost 48 hours without any complications. We were able to get good data up to that point. And she was having cyclic seizures.
How many do we have?
So we have two devices. They're both housed in the NSICU at Mount Sinai Main Campus Hospital. And then in order to make it work, you have to get a disposable headband and just connect it to the receiver.
Seems great.
I really like it.
Do any residents have any questions?
Hey, Alex, it's Kurt. How about monitoring like this for things like continuous monitoring for vasospasm or stroke like that? Is that in use at all in the ICU?
So I wouldn't say not for Cerebell, but for conventional EEG, there have been some published data on the use of quantitative EEG in order to monitor for vasospasm after subarachnoid hemorrhage. There's been a lot of retrospective analyses of this, where you can kind of use things like alpha delta ratio, which is to look at is there an increase in slowing during particular periods that might indicate that there's ongoing vasospasm? It's easier to do retrospectively. I haven't seen a way that it's been done prospectively in order to detect the onset of vasospasm in an operationalized way. But that's definitely an open research question, and I think one that has real promise.
Thanks.
Kate, this is Sadi Gatan. Can you hear me?
I can.
Great job. But I didn't hear anything in there about the surgical management of status epilepticus. And I've been troubled on occasion by patients that have come to our attention that have been in status for months sometimes.
Mm-hmm.
And we have applied vagus nerve stimulation to those patients with somewhat promising results. And there's multiple reports in the literature about this. And we've also thought about applying RNS to epilepsia partialis continua patients in the ICU setting.
Mm-hmm.
Any comments there or reasons why you left it out?
So I left it out because I think that's kind of my status 2.0 talk, where I talk a little bit more about super refractory status. So if I'm asked to come back in a couple of months to give more cases and pearls, I'm definitely going to go into some of the cool treatments that we use for super refractory status, which is defined as status that continues despite 24 hours then anesthetic drip. And I think there are some really promising potential surgical options in that case. Like you've mentioned, we put in 2 vagal nerve stimulators in patients with super refractory status, one with really fantastic results. A patient who had new onset refractory status epilepticus, NORSE, who'd been in status on max dose midazolam, ketamine, and pentobarbital for, as you said, months, who responded really well to vagal nerve stimulation, is now out of the hospital and back living a functional life. So, and another case where I think it was helpful, but it wasn't as dramatically helpful. So I think initiation of early potential surgical evaluation of patients in super refractory status is really, really helpful. And I agree with you that RNS seems like a really promising potential therapy for both epilepsia partialis continua and potentially for refractory status of other types as well.
Yeah, there's a third case to add that did not occur at Maine, as you call it, which was at West recently, and a patient recognized by Yakov Gologorsky, our famous alumnus out at in New Jersey, and sent to us. So I think it is effective, and I also think that it's important that we make sure that we get our epileptologists involved in this management as well.
Mm-hmm. Couldn't agree more.
Thank you.
Okay, thank you so much. Oh, we have another question there.
Just wondering, for patients who present with a first-time seizure, oftentimes these patients are loaded with AEDs treated empirically and discharged to follow up. Is there any role for using Cerebell in the outpatient setting to continue monitoring patients, more or less like a Holter monitor for the brain?
So in that context, I don't think Cerebell would be quite as good. It's a little bit harder to stay on, and you don't necessarily get as much detail as you do with conventional EEG. So in those contexts, we use what's called ambulatory EEG, which similarly does not have video, but is essentially like more of a conventional array of EEG leads. Patients get hooked up here, and usually in the outpatient clinic, get a big head wrap, like they've just had neurosurgery, and go home with it for 3 days. And that's a pretty common modality for assessing patients who have potentially suspected seizures or suspected epilepsy.
Thanks.
Thanks.
It seems like this might be a better option for a patient who has just had surgery and might have an incision on the top of the head, and this can just go around the side. I haven't seen it applied. Does it require gel? And do you think that might be an advantage to it?
I think that is a real possibility, especially if the surgical site is like high up in the parasagittal area. Although if the reason why the surgery was there is because the lesion is up there, then maybe you're going to miss the parasagittal chains, where you might be able to detect seizures a little bit better. But in my experience, there's less skin injury with Cerebell. I haven't put it directly onto a fresh post-op yet, but we did put it on someone who was post-op day 2 from a craniotomy. And it did seem to protect the wound a little bit better than conventional EEG. So I agree that that's promising.
Really cool. Okay, let's move on to our speakers. Is Sarah Nelson on the line? I don't see you signed on here. So let's start with Spyridoula right now. Spyridoula, are you ready?
I'm ready. Let me just share my screen 1 second.
Stop share.
Do you see what I'm sharing? Okay. So thank you for having me here today with you. And we're gonna discuss about the multimodal neuromonitoring in ICU. So first, to tell you that I have no disclosures, and to give you a background to start, so everyone knows that primary brain injury, it's gonna be followed by a secondary brain injury, mainly through a big cascade of biochemical events, mainly glutamate-mediated damage, oxidative damage, calcium-mediated damage, and inflammation. So the tools that we have up to now, the traditional tools that we use in the ICU to timely detect secondary brain injury is the neurological exam, the brain imaging, and the isolated ICP monitor. However, sedation interruption for a neurological exam, although it's safe and we should do it, sometimes it's not, and it's even not advised to. Transferring the patient out of the ICU for imaging can be harmful, or even doing the imaging in the ICU, positioning the patient can be very harmful. And also ICP monitoring, isolation ICP monitoring, the data are debatable. There was a big study trial in 2012, the BEST trial, that showed that there was no difference in outcome if we treat patient based on the ICP monitor or based on our exam and imaging. So the data that we have up to now, the traditional tools are not very robust, and we need to do something to improve the outcome and timely monitor and find out the secondary brain injury in this population. And in that setting, Neurocritical Care Society introduced and recommended the multimodal neuromonitoring plus the specialized ICU, like taking care of these patients in specialized setting of neurocritical ICU. The goal of these two things is mainly to be able to detect in a timely fashion the brain damage, the secondary brain damage in the acute brain injury patients, to offer an individualized treatment, and very importantly, to be able to understand the pathophysiology of the acute brain injury and the secondary brain injury in order to develop more specific treatments. So the monitoring classically can be divided in invasive, non-invasive, regional versus global. I prefer the invasive, non-invasive separation, and we are going to talk about the most commonly used part in the invasive and non-invasive modalities. So first, we can start talking about the invasive monitor. The most common modalities include the EVD and ICP intraparenchymal bolt, the brain oxygenation monitoring through the brain tissue oxygenation tension, or the jugular venous oxygenation saturation. Something that's very common nowadays is the microdialysis for brain metabolism monitoring, and last but not least, the ECOG, the electrocorticography for seizure detection and cerebral spreading depolarization. We will discuss a little bit in detail for these modalities. So classically, the AVD or the ICP Bolt, we use it for ICP and CPP monitor. The goal for these measurements is mainly to understand the autoregulation and have a personalized numbers for each patient. So using correlation of ICP and MAP, we can have the plot of autoregulation. A positive plot means that there is an impairment of the regulation. And if we plot the curve of the PRX with the CPP curve, we can find the optimal CPP actually, where the point of the minimal PRX is, we can identify the optimal CPP. This concept, it's debatable, but still 60% of the patient, in 6% of the patient, we can identify the optimal CPP. The second part, second tool of the invasive monitor, as we said, was the cerebral oxygenation monitoring. That we can do it local using the brain tissue oxygen tension by placing a catheter through the ICP Bolt. Actually, we can use the multi-channel multi-port ICP Bolt. We can have one with 4 ports that we can place different catheters for different measurements. The advantage of the regional oxygen monitor is that it's very safe. It's a balance between oxygen supply, diffusion, and demand. The only caveat, it's mainly do not place it in the lesion area. If we want to have a global assessment of the oxygenation, we can do it invasively by placing a jugular venous bulb oximetry, calculating the venous oxygen content. It's a balance between oxygen supply and demand. It doesn't take into account the diffusion. Even though it's easier to do, and we can do it, everyone can do it, in the ICU, the quality data are poor. And even though it is safe, the complications that can happen, mainly the vein thrombosis, can be deleterious, especially in patients with intracranial hypertension. Preliminary data have shown that brain hypoxia is a predictor of a poor outcome, independently of the ICP and CPP. A prospective study in Switzerland with 103 patients showed that the longer the brain hypoxia is, the higher the risk of having unfavorable outcome. And that was confirmed also with a multivariate analysis, excluding for CPP and ICP. These data are now trying to be confirmed in a large clinical trial, randomized phase 3, that is currently ongoing, the BOOST 3. So we're waiting for the results. Another tool of the invasive monitor is the cerebral microdialysis. We do that in order to monitor the metabolic state, to understand the brain pathophysiology, and also to guide therapy and prognostication less frequently. How it's done, again, by using a catheter through the bolt. So the catheter from the outside part is connected to a pump where we can infuse the perfusate, which is artificial CSF. The tip of the catheter consists of a semi-permeable dialysis membrane, as you can see, and then there is an equilibrium between the diffusion of molecules, and at the end we collect the dialysate, which reflects the 70% of the molecules of the brain's interstitial tissue. When the catheter is placed, it has to be confirmed by imaging, of course, and what we measure every hour is the glucose, pyruvate, lactate, glutamate, glycerol, and we can calculate the index, the LPR ratio, the lactate to pyruvate ratio. Classically, what we're looking for detecting secondary brain injury is the increase of the LPR with decrease of glucose and decrease of pyruvate. That reflects a switch to anaerobic metabolism, commonly seen in vasospasm, hypoxia, ischemia, fever, and inflammation. A large trial published in Brain in 2011 confirmed that these metabolic markers are independently associated with the outcome following TBI. They had 223 patients that had microdialysis for 4 days. The average duration of microdialysis was 4 days. And it was found that the increased total of glutamate and the LPR predict mortality. And of course, by doing the multivariate analysis, confirmed that low glucose and high LPR are independent positive predictors for mortality, whereas high pyruvate was an independent predictor of good outcome. Last but not least, one very important tool of the invasive monitor is the electrocorticography, or ECOG, as we say, that can be done with either the 8-contact depth electrode, again placed through the bolt, or the 6-contact subdural strip placed surgically. Both are relatively safe. Mainly data from epilepsy surgery show that they have kind of equal safety. Depth electrode tends to be a little safer with less complication. However, the rate of infection and main adverse events are the same. ECOG is mainly used for 2 things. It has higher sensitivity for seizure detection, and then like multiple smaller studies that they have showed that. I show you here 2 of them. One in 14 patients, they found 10 patients had seizures with the depth electrode, and only 4 of them had seizures in the scalp EEG. Another bigger, larger trial showed that 48 comatose patients suffering from Subarachnoid, 38% had seizures, intracortically detectable seizures, whereas only 8% of these patients had seizures detected on scalp EEG. The big advantage of the ECOG is the detection of cerebral spreading depolarization, which is a new term in the neurophysiology world. Actually not that new. It was first described in cortex, in rabbit cortex in 1944. Then from 77 were correlated with cortical ischemia, and classically in human and more consistently it's studied since 2002. Cerebral spreading depolarization, actually, we're talking about waves of mass neuronal and astrocytic depolarization starting and propagating from the cerebral cortex. And the rate of propagation is between 1 to 9 millimeters per minute, usually 3 to 5. And they occur actually in most forms of acute brain injury. Just to have an idea how you can see them in the unfiltered ECOG strip data, you see the depolarization that they start and spread. And then if we do it in the quantitative EEG monitor with a filter, you can see the spreading depolarization that starts here and goes up. It can go with whatever direction, it can go from up to down or wherever, but it has to spread and typically start with a depolarization. Why this term is important is because in the beginning, actually, we believed that they were the result of the primary brain injury. However, it has been shown that they appear independently of what's happening with the primary brain injury. It is believed to be a part of the secondary brain injury. They're associated with tissue injury exacerbation, with increased lactate, increased LPR and glutamate without having an anaerobic metabolism or ischemia. And when they appear in clusters, it has been shown that they are correlated, they are associated with a worse outcome. The big, the goal actually, the bet is to find out scalp EEG features that detect CSDs. And that because not every patient has invasive monitor and not every facility can support this kind of monitoring. We conducted this past year study at NGH with 35 patients suffering either from Subarachnoid or TBI. We found 124 CSDs events. Unfortunately, we found, or fortunately, we found no significant association between CSDs and continuous EEG. However, it's a small study and we need larger population to further look into that. So now we're going to talk about the non-invasive part of the monitoring. More commonly tools used for non-invasive monitoring is the transcranial Doppler, the ocular ultrasound, and the EEG. Less frequently, the evoked potentials, and mainly the somatosensory ones. So to talk a little bit about them also separately, they have much less lower accuracy for predicting ICP or secondary brain injury. So many groups tend to combine them in order to check on their predictor character. We did here at Mount Sinai 1 year ago a small prospective pilot study with 14 patients, all of them having EVD, and we had a total of 21 measurements, and we found that the presence of 2 or more of optic nerve sheath diameter more than 5 millimeter, unilateral or bilateral presence of optic nerve disc elevation, and mean MCA-PI more than 1. If you have 2 or more of these parameters, it's very sensitive and specific for predicting ICP more than 15, with an area under the ROC of 0.97. This is very important, especially in patients that they cannot have an ICP monitoring, and also in order to understand the importance of the non-invasive monitoring assessment. Classically, Neurocritical Care Society and Brain Trauma Foundation recommend EEG for every patient with acute brain injury and altered mental status. Continuous EEG or routine EEG, classically used in this setting for seizure detection and status epilepticus treatment, as also Kate mentioned earlier. A very important part of the EEG in the ICU for this population, especially the ones with altered mental status that have no seizures, is to test the reactivity. Most of the data that we have is from post-anoxic population after cardiac arrest. We have shown in different studies that reproducible reactivity during targeted temperature management or after, it's a very good prognosticator tool for good outcome. And again, for common population, this is less established, though can be extrapolated and testing the reactivity in all these patients with altered mental status. Important thing is to know how to test the reactivity, because many times we say it's not reactive, whereas it is. So we have conducted back in 2015 a study comparing different noxious stimuli to test the EEG background reactivity in 77 patients of the ICU. We found that bilateral nipple pinching is the most accurate for testing the EEG background reactivity with a very good P value adjusting for all the other confounders. Last part of the non-invasive monitor that we're going to discuss today is the evoked potentials. Again, the data that we have, the more robust data that we have for the evoked potentials come from the cardiac arrest post-anoxic population. Classically, is the somatosensory evoked potentials. We know that bilateral absence of N20, we see here that's a normal SSEP. And here we have the peripheral waves, but we don't have the cortical one, the N20, in both sides. And we know that bilateral absence, it's a very robust prognosticator for poor outcome. In post-anoxic population, also smaller studies have shown that can be extrapolated in coma. Unfortunately, other evoked potentials like brainstem auditory evoked potentials or transcranial motor ones, though classically used in the OR or even as outpatient, they are not they're not very frequently used in the ICU setting, though we should start trying them more. So to sum up, what we discussed up to now is that the traditional monitoring fail to timely detect secondary brain injury. And newest ways of assessing the secondary brain injury involve a big variety of invasive and non-invasive techniques, even much more than what I mentioned. Each technique separate have moderate accuracy. Some are more accurate, some less accurate, but alone each technique cannot be used. Unfortunately, up to now, we have no randomized trials for assessing the benefit of multimodal neuromonitoring and for assessing the combination, which combination will be the more effective, both for outcome, both for cost effectiveness part, and for better understanding the brain pathophysiology. So what we definitely need is data in large population places. And the hypothesis behind that is that combining invasive and non-invasive techniques with the molecular biomarkers will help us understand and underline the pathophysiology of acute brain injury, timely detect secondary brain injury, and of course, develop treatments in the future. And to do that, we need to have standardized protocols for the multimodal neuromonitoring, including at least the tools that, the tests that we just discussed, and also develop CSF biobanks. That it's a trend that started happening in many institutions in order to develop also standardized techniques for molecular biomarkers. And that's it. I hope it wasn't too much. Any questions?
Hey, Spyridoula. This is Alex. I'm one of the neurosurgery residents. Thanks so much. This was awesome. I totally agree with you that we need more standardization with our intracranial monitoring. I'm just curious, now on service, just for context, we have a patient with high-grade subarachnoid hemorrhage who a ROMAC has actually been very helpful in predicting and treating vasospasm. I'm just curious from your perspective, what you see as far as standardization for high-grade subarachnoid hemorrhage and how we can use ROMAC, because I've seen that we don't really have great standardization now as far as use, and just kind of what you foresee the role of some of these intracranial pressure monitoring and ROMAC with PbTO2 monitoring and what the potential implications are as far as standardization.
Well, I think that it would be very important for every patient with high-grade Subarach to have almost all of them had EVD, but to place also Romedic or other ICP bolt. The important thing, we need 4 ports, because I really believe that we should put also the depth electrode, the ECOG. So I think Romedic has 3 ports, but whatever company, that doesn't matter. But I think it's very important to have both the invasive, like the bolt, and the EVD, because EVD is very important for the CSF biomarkers, other than a treatment, of course. But for developing new tools, it's very important to collect CSF for having biomarkers. But in order to have the oxygenation, to have the ECOG and the microdialysis, we need the bolt. And it's very safe. It doesn't increase the adverse effect. And I think that, of course, it's an extra work for neurosurgery perspective, but I think it would be very useful to do it standardized to every high-grade Subarach patient, or even like every other acute brain injury pathology with comatose population.
Dr. Tsetsou, my name is Ernest. I'm the chief resident. That was an outstanding talk. I want to first point out Dr. Divaldo Camara's question in the chat about whether there's any role for cerebral EEG in severe TBI patients as a quick seizure assessment. So that's one question. And then my own question is, with regard to cortical spreading depolarizations, are you familiar with any of the literature about ketamine for treatment of those spreading depolarizations, and what's the current state of, is there a role for ketamine in the clinical setting?
So first, for the ketamine, I'm not aware of any literature for treating the CSDs. There's some trend now that they started treating, but there is no big, large trial for treatment, especially with ketamine. I will look into that, but I'm not aware for ketamine treating. In theory, yes, it could be a good treatment because it's an MDA antagonist, so it should be effective, but I am not aware of any trial for that. But happy to take a look into it. The other question for the cerebral, it's not a part of the multimodal neuromonitoring because also something very new. So guidelines of neurocritical care, also they're like very old, published in 2014, haven't been updated since, but also cerebral concept, it's very new. So yes, we can do it as an institutional guidelines part and see if it's useful for a quick assessment, knowing that if it's negative, doesn't mean that you don't have seizures. Even scalp EEG, it's much less accurate for seizure detection. That's why we need also the depth electrode. But it would be a very interesting point to correlate also with depth electrode, especially in case that we don't have scalp EEG to cerebral and depth electrode.
Thank you so much.
Spyridoula, sorry,
Hey,
just a
thanks
quick
a lot.
comment.
Oh,
Sorry, guys.
go ahead.
Thank you so much for a wonderful talk. And that again shows why grand rounds are so important. We are such a big center. And unfortunately, we did not realize at the Epilepsy Center your interest in this, and we would love to continue this work. It stopped when Meg Payne left as one of our residents, but we have safety data on depth electrodes. We're at 2,500 depth electrodes over the past 5 years. And we most certainly would love to collaborate on patients that are critically ill. We know the safety data is there, and I think we can get this done fairly expeditiously since we have the technology to do it both at East and at West.
Perfect, thank you very much. It's interesting.
Well, that actually is a good segue to my question. Thanks a lot for your talk. But I was wondering, Spyridoula, if you had any information on the risk between a single lumen bolt versus a quad lumen depth electrodes versus just intraparenchymal ICP monitor. Is there any data that distinguishes the two different types of bolts?
There are no data comparing the two types of bolts. Classically, like I know that in the beginning we're doing 2 bolts before the 4th port appears, but now there's a very good paper of Dr. Foreman, which is a very guru of the neuromonitor, multimodal neuromonitor, advocating for the 4th port lumen. But there is no direct comparison between the 2 ports or the 2 bolts versus 1 bolt with 4 ports. Logically, the 1 bolt with 4 ports should be better because you have 1 bear hole than 2. But again, even the 2 bolts, there were data from Columbia, actually, Dr. Klassen had published, I think 2015 or 16, showing that it's very safe, even with the 2 bolts. So whatever everyone has on availability, of course, if I get to choose, I would prefer the 4 ports. Hello?
Okay. Any other questions? That was fantastic, Spyridoula. Thank you. I think there's really a lot of interest in getting this going among the residents and attendings. So thank you very much.
Thank
you. Sarah Nelson?
So stop sharing.
Yeah, if you stop sharing. Oh, fantastic. Sarah, we can't hear you. Are you muted?
Yeah, sorry.
Okay, there we go.
Yeah, just trying to figure out the share screen thing again. So sorry for the delay on logging on today. I'm actually on service right now at my current institution. We have a couple sick patients in the unit. In any event, thank you so much for the opportunity to present today. So today I'll be talking a little bit about some of the work that's been done in the field of MRI and subarachnoid hemorrhage, and some of the work that I've also contributed to as well. And then on the right there, just because we can't travel anymore, it seems, is just a picture from Amsterdam in June 2019 when I was there. So good to think about some good times there, and some disclosures that I have. Some of this research is based on an internal grant I got a couple years ago at Hopkins, and also some funding from the Brain Aneurysm Foundation as well. So MRI and subarachnoid and aneurysmal subarachnoid hemorrhage, it can be a potentially useful tool. It obviously provides a lot more detail, as you know, about structure and function and physiology and pathophysiology of these pretty highly complex patients. But some higher soft tissue contrast than CT as well, lack of radiation risk as opposed to things like CAT scans. But there are some notable drawbacks, as I'm sure many of us are aware from practice, and including the fact that there could be the risk of artifacts. A lot of our patients aren't stable enough hemodynamically or ICP wise, or other reasons why they can't undergo MRI, and particularly in a timely fashion as we may want them to go. But it seems like there still could be some utility for this modality, and that's what I'm going to show briefly today. So what can it do for us? Well, to start off with, we know that it can help in diagnosing subarachnoid hemorrhage where CT is ambiguous, both early on, just after rupture, and in the subacute phase. It does a better job typically than CAT scan can. There's some nice studies out there, primarily case reports, that show that particularly when you add contrast, it may help identify ruptured aneurysms, and it also can help identify aneurysmal occlusion. And I already discussed previously that there are some reasons why this modality isn't used a bit more. So this is just one example where CT may not do as good of a job as showing SAH. And why this is important? Well, we know that the risk of rebleeding is particularly high after initial aneurysm rupture. And so making sure that we have the right diagnosis is critical. So on the left there, we have a CAT scan that, as we can see, there's a dot of hemorrhage there that is ascribed to an EVD tract related injury. But as we progress towards the flare and the SWI sequences in the right side and the middle panels there, you could see from the arrows that there's not only evidence of flare suppression, which is indicative of the presence of blood in the middle panel, but on the SWI, as I know a lot of us are very familiar with, you can see the evidence in many of the sulci of hemosiderin. And then this was just some nice examples of when you add gadolinium, you can actually get a pretty good idea if there's been rupture of an aneurysm, and they show this both in this panel down here, pre and post GAD. And unfortunately, the Zoom is right over me, where I'm looking at this panel on the right here, where they basically used gadolinium to try to differentiate which aneurysm was considered the culprit of the aneurysmal bleed. And in this case, we see that I believe it was the ACOM that they showed here that is highlighted in contrast after gadolinium administration, and was therefore deemed to be the culprit lesion. There's some data out there, and I won't get into this in depth, but there's been some literature in the past few years that have attempted to document a little bit about some of the findings of diffusion weighted images, ischemia, and some of these patients. This was a review from Stroke in 2017 that tried to showcase this in a few different ways, and I just only show a couple of it here. But what was kind of interesting is pre-treatment, so that means prior to aneurysm secretement, and post, there was actually a fairly significant amount of DWI lesions that were documented in what was a fair number of patients. So this was just a forest plot that showed that pre-treatment DWI lesions, the prevalence there is hovering around 50%. So this could be a relatively common occurrence in these patients. And there can be some potential relationships with how old you are and the number of lesions. So you could typically have a few more if you're older. There may be some sex-related differences too in this relationship. So some interesting things that have come out of this, but this review kind of just basically showcased some of these findings without giving a little bit more detail on why some of these things might actually be. And there might be, which is not too surprising, a relationship with clinical condition as well as DWI lesions. And that's shown here with about 47% between 72. I'm sorry, this is a different forest plot that was looking at between 72 hours and 21 days, showing that DWI lesions appear in almost 50% of folks who were scanned during that time. So we also, a couple of years ago, we did a bit of a review to use kind of pull together some more of the data, including some of the studies that were discussed in the previous review, also discuss other sequences and findings as well to get an idea of the relationship of MRI findings, a variety of MRI findings, and things like neurologic severity, outcomes, and even if there's a differential, if there are differential findings between people who are clipped versus coiled. And so basically what we found, and this was a review to be clear, so it wasn't in a meta-analysis, and so given the variety of findings that we found and the fairly little data per sequence we did find, but to a general degree, it seemed as if the presence and or size of the MRI lesions were associated with more severe neurologic exam, and this was also measured in a variety of ways, which also would make meta-analysis complicated. And so we attempted to show this here in a few different tables where I've just highlighted a few, but DWI lesions being noted in more poor grade than good grade Hunt and Hess patients, as you could see here. And then there was even what came up in the literature, flare lesions, which isn't too surprising, and the volume being greater than 25-fold, and worse off irreversible subarachnoid patients and better off patients, at least in this particular study, which actually had a fair number of patients actually. And then this same glimpse at again, still looking at neuro exams during the acute hospitalization showed that you could see some differences in amygdala and hippocampal volumes down the line that were correlated to the patient's exam when they were in the hospital. So typically smaller volumes, which is probably not that surprising, as well as hemosiderin deposition also being correlative to the patient's exam as well. And then just to provide a few examples, this was just a patient here who obviously has a variety of lesions, both on diffusion and flare, in this Hunt and Hess 4 irreversible subarach patient. So not kind of, you're seeing the correlation kind of on at least a small scale here with just this one patient. And then there's some additional things that we can look at as well. So this is an example, for instance, of looking at a patient with Hunt Hess 5 on the top as compared to Hunt Hess 3 at the bottom. And it's fairly clear that on the DTI, which is the panels on the left, there's more rarefication of the white matter tracts, as you can see there, which are juxtaposed to the lateral ventricles, and there is in the Hunt Hess 3 patient. And similarly, there's definitely more abnormalities seen on the flare in the Hunt Hess 5 as compared to the Hunt Hess 3 patient. So these are just some examples. Obviously, there's more examples that we see every day of this, but we can see kind of the contrast here. And then generally speaking, in the same review, as mentioned, we also looked a bit at correlations that have been seen in the literature between a variety of MRI findings and outcomes. And similarly, given the variety of findings that we saw in the literature, it didn't seem prudent to conduct a meta-analysis. But to a rough degree, we saw basically changes such as increases in flare volume correlating with increases on the modified Rankin scale, which, as you recall, is a scale from 0 to 6, higher being worse, a functional outcome, basically 6, you're dead. And then even findings this time around, this paper specifically was looking at functional connectivity in the context of BOLD, using BOLD fMRI, and seeing that there was more WI lesions in impaired patients than not. And they also looked at some functional stuff too, but I don't include that here in this example. And then some differentiation in Karnofsky score with relationship to number of hemocyanin regions. So that was another interesting finding from this review. We have started by, we've done a little bit of preliminary work on a project that is utilizing some of this. So basically the overlying thing is part of some of these grants that you saw up front. We've scanned actually around 50 or so patients at Hopkins, either for clinical reasons or with the grant funding that you saw. And basically the thrust was to help with the idea of outcome prediction and in helping in this disease, since aneurysm of subarachnoid hemorrhage still doesn't have great prediction models. We know already that, you know, baseline clinical exam is our best predictor as at the present moment. Can other things help us in prediction? And so one of the you know, one of the things is could different types of MRI findings, could that help us with that? And so this slide here is unpublished work that we're starting to look at, where we drill down a little bit more into in our own work that we've collected ourselves, or diffusion and flare related changes, and whether or not this might be different, such as compared to controls, and then also versus outcomes. So this particular table here, and again, this is unpublished, and so it's still a little bit raw data, but taken as a whole, we have the controls in the middle column and the patients in the left-hand column. And these scores down at the bottom is kind of what I wanted to focus on here. And this is taken from a paper that in 2015 attempted to categorize diffusion and flare related findings based on number and severity. It was a paper published by Karen Hirsch, who's at Stanford. And we decided to use that because frankly, there aren't a lot of scales that look at MRI and attempt to categorize lesions and then also attempt to correlate with outcome. And that paper that Karen Hirsch wrote, the idea was to correlate the lesions in cardiac arrest patients. So maybe not the best measure in us for Subarach, but frankly, it's one of the best scores that we have. So when we just look at this table here, some of these scores here, so higher is worse, meaning greater severity of diffusion and flare related lesions, where DGN, by the way, stands for deep gray nuclei. In general, you can see that there seems to be a correlation between a greater number of lesions that are found in the patients versus the controls. And again, the patients are this column right here. So it didn't correlate for all of the components of this particular score. And then this is table is again looking at outcome at 6 months, of which we have some data from several of the patients that we looked at. And again, if we just kind of focus in on these scores here, I'll do that in a second slide, and the next slide rather. So again, MRS greater than 2 here is on the left, so those patients are worse off. And so if we look at those also, there seems to be some correlation where generally higher scores are seen in the patients who are worse off at 6 months. So again, this is all unadjusted univariate analysis, and so unpublished and still a little preliminary, but perhaps there might be some potential if we added to some of these findings to multivariable analyses, that there could be some possible augmentation of prognosis of these patients. That's at least our hope. And then, as I mentioned earlier, you know, there's some, what we had found in doing the review that I was discussing earlier is, you know, there could be some differences potentially in MRI lesion burden in people who undergo clipping versus coiling. And so it seemed like in general, there seemed to be a greater incidence of lesions in those who underwent surgical clipping. But once again, this was a review. It wasn't designed to be definitive, and we don't actually have all of the definitive numbers on this. And just quickly at the end here, I just wanted to go over some of the newer sequences that have been part of the thrust of the project I was discussing earlier, where we've been MRIing these patients. So a lot of what we've been trying to do is multimodal stuff. So not just diffusion and flare that I've previously talked about, but adding on stuff such as arterial spin labeling, which looks at cerebral blood volume, diffusion tensor imaging, which looks at white matter tracts, and bold fMRI, which looks at functional connectivity. And we've started a little bit, some preliminary data analysis based on the patients that we've gotten to date. So, so ASL in brief, as I mentioned, it's basically the idea is to look at cerebral blood flow. And the nice part about ASL is that it doesn't require an exogenous tracer. It's all endogenous. So it relies on arterial blood to make this happen. And so as a consequence of that, it can be a nice thing that, you know, we don't have to worry about kidney function or that sorts of things, or worsening kidney dysfunction. And so there have been some initial data that suggests that decreases of CBF on ASL can correlate with clinical symptoms, and that also that there could be a good degree of inter-rater reliability with the sequence. And this is just data that I presented at the NCS last year when it was still in person, which was some data. And this is only at the time of the course of my study, this is only about 34 patients. And again, the 10 control patients. And what we were trying to show here is that in areas of the brain that are critical to consciousness, and some of these networks, such as the default mode network, the salience network, that there seems to be a decrease in cerebral blood flow in some of these patients in these critical areas as compared to controls. So again, we still are looking at some of these data. I just got my last outcome data for this project yesterday for 6 months. So hopefully there'll be more data on the way. DTI has been, as I mentioned, another focus of this multimodal MRI project that we've been doing. And so DTI, the main thrust is that it uses diffusivity vectors of water molecules to track the integrity of the white matter tracts. And there have been some anecdotal studies. There was one that was published in Stroke that showed maybe fractional anisotropy values that were taken from DTI were lower in the cerebellum. That this increased the odds of noting delayed cerebral ischemia in non-traumatic SAH patients. So not quite the same patient population. They weren't definitively aneurysmal. And we've done a little bit of preliminary research, and this is also still a little bit kind of raw data, but this just kind of gives you an idea of some of the work that we've been trying to do to try to analyze this work. And actually, I think I mixed up a couple of these slides. So let me just go quickly to this, which is one of the other ideas that we would try to, one of the other sequences that we try to analyze as well. So bold sequencing using fMRI. So basically it confers, as I mentioned, regional functional activation. And in some studies, there's been some suggestion that bold activity can correlate with cerebrovascular reserve, that also that increased bold activity in many cortical areas can correlate with the associated with impairment of working memory performance is listed there. And basically we've done some work on this. This here is an example where we've been looking at adjacency matrices. And again, this is still very preliminary as well. You could see kind of the brain regions there on both sides. And again, the null line here is the one that's kind of at this 45-degree angle here. And this brain here on the left here, which is an attempt to look at some of these networks as well. So again, very preliminary and looking at some of these networks and their connectivity, but hopefully we'll continue to have more data. And again, this project generated a ton of data from these fMRIs. You know, I'm taking a course now through my MPH courses, and it turns out that medical imaging comprises the largest proportion of basically electronic storage space in the world. And I don't think that's any surprise, because we certainly generated a lot of data from this project. So just a brief, because I'm going over time, I think perhaps, but there's a couple other sequences that are still somewhat experimental that we haven't yet added to our protocol. Trust is a sequence that hasn't been used in subarachnoid hemorrhage, but the idea is that it could be combined with other types of measures such as cerebral blood flow to estimate oxygen extraction fraction and cerebral metabolic rate of oxygenation. So it could be a potentially useful sequence that could be used in subarachnoid hemorrhage, but still pretty experimental. To my knowledge, has only been done in controlled people so far. And then magnetic resonance spectroscopy, which my understanding is no longer reimbursed by some insurance companies, but in any event, the idea being to analyze regional metabolite concentrations. And there's some studies that, maybe it helps detect ischemia in SAH, maybe it doesn't. It seems like the jury's a little bit still out regarding that, but has the potential perhaps to be useful, but again, not used as much probably because it's not well reimbursed. So conclusions that I have here. So MRI and SAH, it seems, as I mentioned at the top, it is potentially hard to do. There are some obstacles to try to get it done and some artifacts that could get in our way. But it seems that, at least from the preliminary data that we have, that it could be somewhat promising, though there's still a lot of data out there that needs to be done, and even in the project that I've been doing, that still needs to be analyzed. So could multimodal MRI be added as an addition to prognostic models in this disease? Well, that is a little uncertain too, but it seems like there could be some potential there. And then some uniformity in studies might be useful too. Getting more patients, doing a more uniform type study where it's possible to actually do a lot more rigorous quantitative analysis to kind of drill down and see if this is actually a useful modality that can be used in prognostication in this condition. And so I just wanted to thank some of the folks I've been working with at Hopkins on this project, the top two being the main mentors I'm working with, but a good deal of these folks have been either undergrads who've really stepped up to the plate, or some imaging folks here who've really done some fantastic work and have helped me out a lot. And then the picture on the right, if we're being nostalgic again and thinking about times when we used to travel, is from Honolulu in 2013 when I was there for the ISC. And that's all I had. Thank you.
Thank you very much. I know there are a few questions.
Hey, Dr. Nelson, thanks so much. This is Alex again, one of the neurosurgery residents. I think it's awesome, some of these MRI sequencing with BOLD and TRUST. I just had a quick question about the actual utility of them. Are we able to do it on a regular 1.5T scanner, or do some of these sequences require like a 3 or 7T? Because I know in the past we've had trouble getting some of these critical inpatient patients to an outpatient scanner. So I just questioned kind of the utility of some of these sequences and the usability of them in the acute care setting.
Yeah, it's a great point. I should have brought that up as well, because it's not always feasible to get these patients to the scanner that you want them to get the scan done for a variety of reasons. Most of the sequences that I mentioned are kind of more designed for 3T, particularly the BOLD and the DTI and things of that nature. So it is more designed for that, for 3T. And I will also say that towards your point about, or how you brought up outpatients there, it turns out that one drawback to our study has been the fact that the outpatients were actually scanned on a different 3T scanner than the ones that were inpatient, and that is strictly because of the practicability of and the safety of kind of transporting these patients to a scanner where they'd be safer than going to like an outpatient center scanner, say. You're right. And then the other issue too that sometimes arises too is sometimes these patients, some of the instrumentation that they get for aneurysm securement isn't always compatible with 3T, but is for 1.5T. So that's sometimes an issue that has come up as well. So it's a good point.
Great, thank you so much.
Are you using DTI clinically, and do you know anybody doing that where the radiologist is analyzing the DTI and making comments with DTI in the interpretation?
Yeah, it's a good question. So it turns out that I don't think a lot of people are using it clinically. A lot of the times, frankly, when I've run this protocol with the sequences that I discussed, including DTI, the radiologists almost seem to kind of breeze right over that. And the findings at the bottom that, in the discuss the pressure of the report are generally related to the diffusion and flare and SWI and all the, the typical sequences. And so, and definitely less so on the DTI. But our hope is, and this is what we've been trying to do through this project, is try to come up with a way that these diffusion, the DTI, the BOLD, those types of sequences, it could be run in a relatively quick manner, like an hour or so, so that we actually do get useful data that can be actually helpful to the clinician in real time. And that's been kind of one of the hopes from this project.
Great. There is some software that we use in the operating room that will give you a quick and dirty DTI assessment.
Oh, cool.
Then you're able to incorporate that into your trajectory planning.
Okay.
And it doesn't give you, at this point, quantified measurements, but it does let you at least see and estimate what tracks you're going to go through with different trajectories.
Okay.
So there's kind of some preliminary automatic processing available through BrainLab, and I think a few other companies have that.
Okay, that's awesome. Yeah, I'd love to learn more about that too. So that sounds really cool, really interesting.
Any other questions? Okay. Sarah, thank you so much.
All right, thank you.
Really fantastic. Thanks for taking time while you're on service. We appreciate it. Look forward to seeing you here.
Yeah, thank you. You too.
All right. Thanks, everybody. Have a great day.